who is a difficult subject, where is not an easy module in the course of radiology, but we are trying to simplify matters as much as we can. And I hope you have benefited from the lectures that you heard before, and we will try to present some of the cases to revise your knowledge. And this is the first case with showing an MRI of the brain, T2 and T1 flare, T1 post contrast, the sagittal T1 post contrast. Okay, and the first answer is good. This is craniopharyngioma, and the answer is right. You got the suprasellar lesion, which is partially cystic and partially solid. The solid component is enhancing, then you are dealing with the craniopharyngioma. There are three main criteria for the craniopharyngioma for to reach the diagnosis: cystic component, solid component, and calcium. And you know that MRI is not that sensitive for the detection of calcium. Then two criteria of the three can fit for the diagnosis, especially the cystic part, which should be one of the two. Then you may see a cyst with mural calcification, like in the CT scan. This is good, or a cyst with a solid component, and this in MRI, and also is helpful for the diagnosis. The next case is for this sphenoid sinus lesion. Yes, and the answer is right. This is fungal sinusitis, and you got what looks like a polyp inside the sphenoid sinus. The polyp is relatively hyper intense in the T1 weighted image and is dark in the T2 weighted image with the rim of hyper intense signal. This is the regular inflammation, and this is the fungal infection, which is of relative dark signal in the T2 weighted image. Next case is a male patient, 41 years old, with swelling in the left lower eyelid and a orbital or periocular pain. Yes, this is not a pseudotumor. This is a mass, or what looks like a cystic lesion in the region of the ethmoidal air cells, and this lesion is of bright signal in the T1 and less bright signal in the T2, meaning that it contains fat. And cystic lesions in the head and the neck containing fat are usually diagnosed as dermoid cysts, and this is a dermoid cyst in the region of the medial orbital wall encroaching on the ethmoids. Someone may think about a mucocele in the anterior ethmoids, but you can see clearly that the ethmoidal air cells are not expanded, and the ethmoidal mucocele is somewhat bright in the T1, not that brightness which is similar to the fat. Then it is a dermoid cyst. And this female patient She had a progressive swelling on the left side of the neck. She had discovered peritonsillar abscess. And previous case, he said that there is a lesion in the sphenoid sinus. No, the sphenoid sinus is clear, and this is the anterior clinoids, which contain fat, and it shows bright signal in the T1 weighted image. Yes, and the second case is, as you have answered, this is a branchial cleft cyst second arch, typical location, posterior to the submandibular salivary gland, anterior to the sternomastoid muscle, lateral to the carotid artery and the jugular vein. This is a classic appearance of a branchial cleft cyst second arch. Next case. This is the non-contrast CT, arterial phase, venous phase. Ectopic thyroid. No, the thyroid is at its regular location, and there is no abnormalities in the thyroid gland itself. But if you look carefully posterior to the left lobe of the parotid of the thyroid, and you see this nodule which shows some enhancement in the arterial phase and wash out in the venous phase, and this is of course a parathyroid adenoma. If you look carefully here, this is the carotid, and this is the internal jugular, which are enhanced. But here you see the carotid and the internal jugular, and this is an extra abnormality, which is located posterior to the left lobe of the thyroid gland, diagnostic of parathyroid adenoma. Next case, and this is MRI of the sella. This is coronal T1, coronal T2, sagittal T1 without contrast. All images without contrast. Yes, and this is pituitary adenoma, and it's not simple adenoma. This adenoma as you said, the cystic changes, and inside the cyst you got hemorrhage, and the hemorrhage is bright in the T1 weighted image and also is bright in the T2 weighted image, and this is known as pituitary apoplexy or hemorrhage in the pituitary gland. Then and hemorrhage in a pituitary adenoma, of course, and this is known as pituitary apoplexy. And the patients with apoplexy present with headache, visual deficits, ophthalmoplegia, or sometimes altered mental status. And these symptoms are due to rapid expansion of the infarcted hemorrhagic pituitary adenoma. The causes or the risk factors for the development of hemorrhage inside the pituitary adenoma are the trauma, anticoagulants, bromocriptine therapy, diabetic ketoacidosis, radiation therapy, open heart surgery, and increased intracranial pressure. Apoplexy or hemorrhage in the pituitary adenoma is seen in about 5% of the cases, and 50% occur in patients were not known to harbor a pituitary lesion, meaning that the patient had a pituitary adenoma and doesn't know, and after the development of hemorrhage, the adenoma has much enlarged and started to present by symptoms. The next case is a male child, 10 years old, with this CT scan of the region adjacent to the oropharynx. Uh, when someone answered that it is carcinoma lymph metastasis. I got your message, and then this is not an angiofibroma. An angiofibroma should be in the nasopharynx, and this is maybe a rhabdomyosarcoma. But initially, you should number one know that because of the smoking at a very young age nowadays, patients may develop nasopharyngeal carcinoma and oropharyngeal carcinoma in a younger age than we used to see. Then this lesion is related to the medial aspect of the parapharyngeal space, meaning that it is of pharyngeal origin, and this is, of course, the oropharynx. Then you are dealing with the pharyngeal lesion. The most common pharyngeal lesion is the carcinoma. And you may say that, as I used to say in the previous lectures, that carcinoma is not common in this age, but nowadays carcinoma can be seen even younger than 10 years of age. Then you should mention first that this is carcinoma whenever you are asked for the differential diagnosis. You should say lymphoma and the metastasis, and also you may mention the possibility of rhabdomyosarcoma. Next case is an MRI. This is T2 weighted images, and this is sagittal T1 post contrast and coronal T1 post contrast, and you got a mass that is protruding into the oropharynx. Yes, and carcinoma of what? Yes, okay, carcinoma of the base of the tongue. This is right. And there is a big mass here in related to the mouth floor and at the base of the tongue on the right side. And you see the craniocaudal extension of the lesion in the sagittal image, and you can appreciate clearly the presence of metastatic lymph nodes on the same side of the tumor. And this is carcinoma of the base of the tongue and associated with lymph node deposits on the right side. Then, actually, if you are asked what are the differential diagnoses of this lesion, you mentioned that lymphoma and metastasis are also considered into the diagnostic possibilities. And this is a child 2 years old, and you got this CT scan of the brain and also the orbit. Retinoblastoma with metastasis. This is the answer. But if you look carefully, then you can see that the left orbit there is no lens, and this is the lens, which is dislocated and displaced posteriorly. And in this orbit, you see the lens at its side, and you see what looks like intraocular hemorrhage. Then if you go to the brain scans, you cannot see the ventricles because of the diffuse brain edema, and you got some hemorrhagic shadows in the posterior fossa, And also, if you look carefully here, and you can see some hemorrhage along the inner wall of the calvarium. And this age group, then this will be mentioned in details in the pediatric course. You should suspect what's known as the shaken baby syndrome. This chicken baby syndrome results in significant intracranial injuries in this age of the patient when the child is shaken by his mother or his father. Then you got sometimes you got dislocation of the lens, and you got some intraocular hemorrhage, brain edema, brain contusions, and also some extra axial hemorrhages if the child is shaking vigorously. Then next case is a patient 33 years old with small cell lung cancer. Yes, and I have said many times before, whenever you are confronted by a patient with known primary malignancy and you see a lesion, you should consider this lesion as metastasis until proved otherwise. And if you remember, this looks much to the previous case. And first of all, you should mention the primary lesion arising in this area if you do not know the history, like squamous cell carcinoma of the oropharynx or the base of the tongue. Then you mention the differential diagnosis in the form of lymphoma and the metastatic deposits. You diagnose metastasis by the known history of primary malignancy. This female patient, 45 years old, with painless right neck swelling. Tonsillar carcinoma, and the answer is right. And this is tonsillar carcinoma is bilateral. Then, whenever you are confronted by a lesion in the tonsil, please look to the opposite one because it may be involved by the same pathology. Then, also, you look for the neck, looking or searching for metastatic nodes. And as you can see here, there are necrotic metastatic nodes on the right side of the neck, which are metabolically active on PET-CT. Then the diagnosis is bilateral tonsillar carcinoma and metastatic nodes in the neck. And this patient with I think difficulty in swallowing, and the CT of the neck showed this configuration, and I think that the diagnosis is easy now. Uh, mm, Someone said that this is lymphoma, maybe, and okay. If you look here and you see a mass in the tonsillar fossa or the left side of the oropharynx, inseparable from the base of the tongue and from the lateral wall of the pharynx, then you should say that this is carcinoma. And if you look to the nodes in the neck, they are bulky and homogeneous. Also, you should say that this is carcinoma with metastatic nodes because nodes of the pharyngeal primaries may be bulky and homogeneous. Then, whenever you are asked about the differential diagnosis, you should say lymphoma and metastasis. Okay, then every now and then you should mention the most common lesion in the pharynx is squamous cell carcinoma, and it represents about 98% of the lesions affecting the oro and the nasopharynx. The remaining 2% are left for lymphoma, metastasis, rhabdomyosarcoma, and so on and so on. Then this patient had an ocular pathology with no proptosis. Orbital pseudotumor. In actually, you can you know that orbital pseudotumor involves predominantly the fat and the lateral rectus muscle, and it may produce thickening of the posterior sclera. But you remember also that lymphoma has the tendency to coat the globe, and it produces a soft tissue mass that can surround the globe. Actually, many of the cases may simulate this, of many of pseudotumors may simulate this, and you can differentiate between both using the clinical data of redness and inflammatory signs in cases of orbital pseudotumor. Yes, and this is the male, 48 years old, with an MRI of the oropharynx. This is T1, T2, and T1 post contrast fat sat. And this is the answer is enlarged nodes. Where these nodes? Um, if you look here, and this is the submandibular salivary gland, and this is the opposite one. They are not symmetric because the patient is somewhat tilted, but the pathology is located here on the right side of the oropharynx, and you may got this lymph node. This is node, actually this is the submandibular salivary gland, and this is the opposite one, and the asymmetry because of the patient tilt. You may say that this is oropharyngeal carcinoma. You may say that this is carcinoma of the minor salivary glands, and both are of the right answers, I mean. Then in this patient, 60 years old, you got this appearance. There is a lesion in the ethmoidal air cells with erosion of the orbital wall and some intraorbital extension. Then nasopharyngeal carcinoma. Actually, we are in the ethmoidal air cells, actually, and then this another is fungal sinusitis, invasive fungal sinusitis, antrochoanal polyp. And this is not antrochoanal polyp because there is no communication between both, and the lesion is centered mainly in the ethmoidal air cells. Then this is the MRI, and and you see that there is a mass in the ethmoidal air cells with disruption of the lamina fabricia and intraorbital extension, and this is coronal T2 and coronal post-contrast fat sat. Then you got heterogeneous enhancement of the lesion with extension into the orbital cavity. Then the squamous cell carcinoma is the most common malignancy in the head and the neck, and you should think of this as carcinoma until proved otherwise. actually because of the aggressive nature of the lesion with destruction of the ethmoidal air cells as well as invasion of the orbit. Next case is a child 3 years old with left neck fullness and the bluish coloration of the skin. No, this is not lymphangioma because lymphangioma is a cystic lesion with fluid signal intensity, but here you got the serpiginous pathology with some answer about hemangioma. Yes, you know that the recent name of hemangioma is venous malformation. And under the title of venous malformation, we can list in number one the hemangioma, number two the cavernoma, number three the cryptic or the dural the developmental venous anomaly, and because of the serpiginous nature of the lesion and the low flow of blood inside the lesion, and this arrow points to what looks like a phlebolith, and you got the diagnosis of the hemangioma, or what is known recently by the venous malformation. Next case is a male patient with a mass in protruding into the oropharynx. Carcinoma, lymphoma, metastasis. Okay, then actually, if you are in the exam and you are asked about this lesion, and you say there is a solid soft tissue mass with heterogeneous enhancement located in the upper part of the larynx and protruding into the oropharynx, likely malignant, and there is no evidence of enlarged lymph nodes except for this very small node on the right side, then your diagnosis is a squamous cell carcinoma of the oropharynx. Then whenever you are asked about the differential diagnosis, you say only lymphoma. Then whenever you are asked once more for the differential diagnosis, you say metastasis. Don't say that this lesion is oropharyngeal carcinoma, differential diagnosis, lymphoma, and metastasis. Then you mentioned all what you know, but let the examiner ask you more questions. This will give you more remarks. And this patient with this lesion in the floor of the mouth, and the CT scan with contrast, you got this appearance. This is an MRI T1, MRI T2, and MRI post contrast. Dermoid cyst, and dermoid contains fat, and dermoid is a midline structure, and this is enhancement inside the lesion. And if you look carefully for the lesion before contrast and the lesion after contrast, this is enhancement. Then you should think of a venous malformation once again, because of the enhancement. Dermoid cyst does not enhance with contrast. But I think you may think of dermoid because of these shadows, which may look like the sack of marble, but these lesions may represent calcification. And you know that calcium may be bright in the T1 and dark in the T2 weighted images. And this is a hemangioma, or the venous malformation in the mouth floor. 53 years old male with a lesion at the at what? Yes, at the tongue, and this is of course a tongue carcinoma. This enhancing lesion on the left side of the tongue is carcinoma until proved otherwise. What are diagnostic possibilities? Lymphoma and metastasis. Then in carcinoma, you should say carefully that the lesion is not crossing in the midline, because the extension across the midline will make the lesion inoperable. And also, you look carefully for metastatic lymph nodes in the remaining images if you have. Yes, this patient had an MRI of the tongue, T1 weighted image, T2 weighted image, and T1 post contrast. What do you think? The same answer: dental infection and tongue infection, inoperable tongue carcinoma. Yes, and you see here that this lesion is crossing actually the midline. Then how can you diagnose infection or separate infection from the tumor? This is a big issue actually in the tongue and in the region of the mouth floor spaces. But whenever you see a heterogeneously enhanced lesion without the appearance of true abscess formation and the detection of abnormally affected tooth, then you should think first of the common, which is the malignancy. Then this is a patient with left parotid lesion, T1, T2, T1 post contrast, and the diffusion weighted image. Yes, and this is abscess, a straightforward case, and this is abscess. This is the EDC, and you got diffusion restriction inside the lesion. But in cases of carcinoma, you got a diffusion restriction in the margin of the lesion. This is an abscess in the parotid gland. Yes, this is a lesion in the greater wing of the sphenoid, and here are the diagnostic possibilities: meningioma en bloc, Paget disease, fibrous dysplasia, sclerotic metastasis, and inflammatory lesion in the skull base. Someone said that this is fibrous dysplasia. Any other possibilities? Meningioma, yes. This is meningioma actually, and meningioma en bloc, which affects the greater wing of the sphenoid and lateral orbital wall. You remember that fibrous dysplasia affects the orbital floor or orbital roof in particular, and the fibrous dysplasia is present usually in the pediatric age group. But this is a meningioma en bloc, classic appearance and classic location, or you may call it intraosseous meningioma. It's okay. In this patient, they had diabetes mellitus type 2 with hypercholesterolemia and tobacco abuse, presented with gastroesophageal reflux without dysphagia. The CT images showed this lesion in the region of the epiglottis. And abscess is very difficult diagnosis. That the patient has an abscess in his larynx. Another possibility, and Peripherally enhanced? No, this is not a peripherally enhanced lesion. Polyp? No, it is a cystic lesion. Okay, and then remember that I have mentioned some issues about the laryngeal. And I said that the laryngeal is divided into three types: the internal, the external, and the mixed. And I said that laryngeal may be filled with air or fluid. And if it is filled with fluid, it is called saccular cyst. Laryngeal may be secondary infected, and the secondary infected laryngeal will show air fluid level and show significant marginal enhancement and edematous changes in the soft tissues surrounding the lesion. This is known as saccular cyst, or sometimes is known as pharyngeal retention cyst. Next case is a CT scan of the oropharynx, and you see this is arterial phase and the venous phase. And you got a lesion on the right side, this lesion, which is heterogeneously enhanced. And in order to know the diagnosis, you should locate the lesion in relation to the parapharyngeal fat. If it is lateral, if it is lateral to the parapharyngeal fat, then you should mention part of the parotid gland. But if it is posterior to the fat, then you are in the differential diagnosis of glomus tumor and neurofibroma or schwannoma and lymph nodes. And the answer is schwannoma is right, because this lesion is not that much enhancing to simulate the chemodectomas or the glomus tumors, and is heterogeneously enhanced, and this does not looks like a lymph node. And I have mentioned before that if you see a big lymph node like this, and you should see other nodes elsewhere in the neck, then the diagnosis of schwannoma is good. You may say that this is vagal schwannoma. You remember the vagal glomus tumor. Also, the schwannoma should be posterior to both internal and external carotid arteries. The same location, vagal schwannoma and glomus tumor have the same position posterior to the carotid vessels. And this is the child with a mass in the orbital cavity on the left side. Yes, what do you think? Cellulitis with abscess, actually you see that the fat planes very near to the lesion are quite clear. Then you should see this fluid level, and you know that this is lymphangioma of the orbit. In a child with a big lesion inside the orbit showing multiple or single fluid levels, then you consider the possibility of lymphangioma, and this was orbital lymphangioma. Then next case is also a newborn with a big, very big mass inside the right orbital cavity and protruding markedly anterior the orbital cavity, and you cannot identify the globe. No, this is not an cephalocele and is not a meningioma. The mass contains calcium and fat, which is bright in the T1 and less bright in the T2. You remember that I have mentioned if you Yes, the answer of dermoid is right, but yeah, I have mentioned that if you got a very big mass in the orbit of a child and you don't see the globe, you should assume that the mass is arising from the globe and the diagnosis of retinoblastoma should be considered. But in such a case, especially retinoblastoma, of course, contains fat, but of course contains calcium. But the presence of fat is not one of the criteria of retinoblastoma. It is a criterion of dermoid cyst. And you know that many of the dermoid cysts are present at birth, congenital dermoid cysts. Then this is a huge teratoma in the orbit. Of course, you cannot see the globe. Then next case is a patient with what looks like a soft tissue sheet anterior to the right orbit. The sheet shows hypointensity in the T1 and hyperintensity in the T2 with significant post-contrast enhancement. And the answer is hemangioma. Yes, this is right. Because if you look carefully, you see this arrow which points to what looks like a phlebolith. This is a hemangioma or venous malformation, as I have mentioned before. Then this patient with this lesion that is homogeneously enhanced, located at the orbital apex in the suprasellar and the parasellar area. Meningioma, yes, the answer is right. Meningioma is the lesion in a classic location, homogeneous enhancement and the dural base with extension into the orbit as well as into the cella. Then this is one of the types of skull-based meningiomas that occur in the anterior or in the middle cranial fossa. This patient with a mass in the region of the right maxillary sinus. Yes, carcinoma, this is right. Actually, if you see a destructive mass in the maxillary sinus and extending in the surrounding spaces, the first possibility at all is to consider a carcinoma of the maxillary sinus. And if you are asked about the differential diagnosis, I say many times you mention lymphoma and you mention metastatic deposits. And you can diagnose metastasis if you know that the patient had a primary malignancy. And
Recording in progress.
I don't know what happens, but we will continue. Unmute, okay. Then we'll continue the case. Someone will say to you that lymphoma does not cause significant bone destruction. This is right, and lymphoma may creep between tissues without significant destructive changes, but this is not the rule. You may got lymphoma that can destroy the bones like this one because after all, lymphoma is a malignant lesion. Then this patient with MRI of the brain, including the orbits. Okay.
Recording in progress.
Then, and then there are some troubles with the internet as usual. And then this is bilateral optic nerve glioma. The answer is right because the optic nerve is involved by a mass bilaterally, and you get some tortuosity. You cannot see the optic nerve through the lesion. Then this is bilateral optic nerve gliomas. And in such a case, you should diagnose the possibility of neurofibromatosis type 1. Then the next case is this patient with another optic nerve lesion, which is not a glioma. Yes, meningioma, right? And this is the most classic appearance of a meningioma of the optic nerve with the radiolucent track sign of the optic nerve itself running through the meningioma mass, which is arising from the optic nerve sheath. And this is a classic appearance of an optic nerve meningioma. Then another lesion in the orbit of an infant, 10 weeks old, with gradual swelling of the left eye. Yes, lymphoma, maybe lymphoma, but if you look carefully, hemangioma, yes, and some of the answers are right. If you look carefully, and you can see some of the vessels running through the lesion. Then vessels within the lesion are usually diagnostic of a vascular malformation or venous angioma or capillary hemangioma, which is common in this pediatric age group compared to the cavernous hemangioma, which is common in adults. And this is what we call infantile hemangioma or the capillary type of hemangioma. Then this is an easy diagnosis, of course. Yes, and this is a straightforward case of Graves' disease, multiple muscle enlargement on both sides, with involvement in particular of the medial rectus and inferior rectus. Also, the superior rectus levator complex are involved, and this is diagnostic of Graves' disease. This is a female infant, 9 weeks old, with a huge mass on the left side of the neck. Lymphangioma, yes, this is lymphangioma, big cystic lesion in the neck. And you remember I have said that there are three cystic lesions in the neck. One in the midline, which is thyroglossal duct cyst. Two on the lateral aspect. The smaller one is the branchial cleft cyst, second arch, and the bigger one is the cystic hygroma or lymphangioma. Both can fit. And this patient is actually this age is not right, but you got an adult case with a mass also in the region of the maxillary sinus that has extended into the nose as well as in the pterygoid fossa. Then what do you think? Angiofibroma. So, angiofibroma should be located mainly in the nasopharynx, but this mass is not in the nasopharynx. It is actually in the maxillary sinus, centered over the sinus itself, with some retained secretions, and there are significant post-contrast enhancement. Then you think of carcinoma, yes. You think of carcinoma, and if you are asked about the differential diagnosis, you say that maybe lymphoma or metastasis, and this has been proved by biopsy to be a lymphoma. Actually, the diagnosis of carcinoma should be first because it is much more common than lymphoma. This child, 7 years old, had bilateral sensory neural hearing loss. No, this is not acoustic neuroma. The interdictory canals are patent, and then the nerves inside are well demonstrated. Endolymphatic sac, صح? This is right. No, this is not Mondini, but it is in the endolymphatic duct and the sac, or what is known as vestibular aqueduct syndrome. You see, the vestibular aqueduct on the left and on the right side are much more dilated, and in the T2 you can see the distended endolymphatic sac bilaterally, and this is one of the known causes of sensory neural hearing loss, which is the vestibular aqueduct syndrome. Next case is a child 5 years old with a mass in the nasal fossa on the left side with destructive changes, intraorbital extension, and the erosion of the floor of the anterior cranial fossa. Rhabdomyosarcoma is a good possibility, and also no, this is not fungus, but if you look carefully and you can got matrix calcification inside the tumor, and whenever you got a malignant lesion with matrix calcification, you think of chondrosarcoma. Actually, chondrosarcoma is rare in this particular location, but the presence of calcification inside the lesion and the age group, you think of chondrosarcoma. Next case, this age is not right, but you got a mass in the maxillary sinus with extension into the nasal fossa, and also a component in the cheek. Yes. What do you think? Osteosarcoma, fungal sinusitis. Um, Actually, this is not fungus because the aggressiveness of the mass and the heterogeneous enhancement with the destruction of the surrounding bones. Then, whenever you feel that this mass is malignant, you consider first possibility carcinoma, and you look for the anatomic location of the lesion, maybe the ethmoids, maybe the maxillary sinus, and this was the maxillary sinus carcinoma, which has extended into the nose and some part has involved the nasopharynx. This patient, 58 years old with breast cancer, showed an intraocular lesion on the right side. Yes, very good. These are metastases. And considering the primary malignancy, you should diagnose this as metastasis. If you do not know the history, you diagnose this as malignant melanoma, of course, which is the common intraocular mass in adult. Actually, the literature says that metastases intraocular are much more common compared to the malignant melanoma. But you need the clinical history of the presence of primary malignancy in order to go for this possibility. This patient is 12 months old and the MRI of the brain showed a very characteristic appearance of optic glioma. Okay, actually, if you look carefully here, you see that the chiasm is involved by a mass, and also the visual pathways are involved by lesions, and the diagnosis of neurofibromatosis type 1 is right. But in order to differentiate between hamartomatous involvement of the chiasm and the optic pathways, you look for the contrast enhanced images. If you got real enhancement, you think of glioma. If you do not show real enhancement, you think of hamartomas. In both conditions, the diagnosis is neurofibromatosis type 1 with involvement of the visual pathways. Next case is the female, 20 years old, and this is a very easy diagnosis. Is an optic nerve glioma on the right side. Yes, right. The optic nerve is involved by a mass. It appears tortuous. You cannot discriminate the optic nerve within the mass. All these features are diagnostic of optic nerve glioma. This patient, 25 years old, with imaging for hypogonadotrophic hypogonadism and right eye congenital blindness. The images for the skull base, this is T1, T2, and T1 post contrast. And no, this is not the hot spot. Encephalocele, yes. This is encephalocele, and you see that there is herniation of the CSF through the sphenoid sinus or through the skull base. There is no significant enhancement, and this is trans-sphenoidal meningocele. If it contains some of the brain tissue, you may say that this is trans-sphenoidal encephalocele. This patient, 65 years old, with growing masses on the neck, multiple resections done over 4 decades. Neurofibromatosis, yes, the answer is good. These are extensive multiple neurofibromas with the classic target sign on the T2 weighted image and the homogeneous enhancement on the post-contrast images, and this is plexiform neurofibroma. Next case is a female child, 10 years old, and this is MRI of the cella showing this is T1, T2, T1 post contrast, coronal, and sagittal. Adenoma, no. Erosic cleft cyst, no, it is enhancing. Craniopharyngioma, no, there is no cystic component. No, this is not a craniopharyngioma. This is a hypothalamic glioma. Yes, this is hypothalamic glioma. You got a solid lesion and there is no cystic component. Look for the CSF, and this is a solid component. And if you inject contrast material, this is not a cystic component because it shows enhancement later on, or it is enhanced in the sagittal image, then a homogeneously enhanced mass, or a heterogeneously enhanced mass in the suprasellar area. In a child, you should think of hypothalamic glioma. Next case, male, 66 years old, with neck swelling, and this is CT without contrast, and this is CT arterial phase, and this is also arterial phase. No, this is not a hemangioma. It is a well circumscribed, a strongly enhancing lesion. Parotid is it's a very far from the parotid gland. Glomus, yes, and you consider because of the enhancement, you consider the possibility of a vascular tumor, but in this case, it has been proved to be a schwannoma with malignant transformation. You know, the malignant transformation in schwannomas, now known as malignant peripheral nerve sheath tumor, and is not known as neurofibrosarcoma anymore. Then the possibility of glomus tumor or carotid body tumor may be considered. You can see the carotid vessels entangled within the mass, or you may also think of a hypervascular metastasis, but actually this lesion was proved to be a malignant schwannoma. This patient with a mass centered to the optic nerve on the left side. Meningioma, yes, this is right. Meningioma, in the coronal image, they said that it gives the appearance of a donut sign with the optic nerve at the center of the mass, and it clearly identified whenever you injected the mass with contrast, and this is typical for meningioma. And if you look to the axial image, you can see the optic nerve running through the mass, classic appearance. And next case is also for the orbit. Suberosteal abscess, yes, the suberosteal abscess, and then the diagnosis should be orbital cellulitis with suberosteal abscess secondary to ethmoidal sinusitis. And this is the should be the full diagnosis: orbital cellulitis with suberosteal abscess secondary to ethmoidal sinusitis. And this is the appearance of there should be ethmoidal sinus involvement to diagnose orbital cellulitis. But if the ethmoids are clear, look for another diagnosis. Involvement of the ethmoid by sinusitis, then extension through the lamina papyracea into the orbit, is known as orbital cellulitis, which is quite different from ophthalmitis and the panophthalmitis, where in such cases the ethmoids are not the cause. Then in this male, 49 years old, he got sinusitis of both maxillary sinuses. This is T1 and this is T1 post contrast. This is flare and this is T2 weighted image. Acute sinusitis. For the diagnosis of acute sinusitis, you should have air fluid level. Maybe you imagine this is an air fluid level, it's okay. But what is yes, and then this is fungus. The fungal sinusitis is right because the lesion is bright signal in the T1 and dark signal in the T2 with marginal enhancement. This is the enhancement of the fungus in the paranasal sinuses, enhancement of the mucosa surrounding the fungus. On the opposite side, you get simple sinusitis, which is of dark signal in the T1 and the bright signal in the T2 with some air fluid level denoting an acute exacerbation or acute phase. But the right sinus is involved by fungal sinusitis. Then this is a classic lesion in the region of the pituitary gland, which results in a slight enlargement of the pituitary gland, but significant enlargement of the pituitary stalk when the stalk and the gland are together enhanced. And one of the best diagnostic imaging clues is this constriction at the middle of the lesion, which represents the junction between the stalk and the gland. And this differentiates this particular lesion from the microadenoma. This is not a macroadenoma, but there are actually three lesions that involve the pituitary gland and the stalk. These three lesions are Langerhans cell histiocytosis, lymphocytic hypophysitis, and sarcoid. All the three lesions showed the same criteria with mild swelling of the pituitary gland, swelling and enhancement of the infundibular stalk. In order to reach the differential diagnosis, you need some clinical help. In Langerhans cell histiocytosis, this is a child, and the appearance will go with histiocytosis. Also, you may see some of the osteolytic lesions in the calcareal bones. For lymphocytic hypophysitis, you should have this typical history, which is a female patient in the reproductive period with recent delivery, several months. Then you got headache and hypopituitarism. And if you see this particular history, adult female, recent delivery, and postpartum hypopituitarism, you think of lymphocytic hypophysitis. The second lesion, which is seen in the pediatric age group, is Langerhans cell histiocytosis, which also involves the pituitary gland and the infundibular stalk. In order to differentiate the three lesions from each other, all the lesions present by thickened, enhanced infundibular stalk and prominent enhancement of the pituitary gland. The xenophilic granuloma or Langerhans cell histiocytosis is a childhood disease, and it may be associated with lytic bony lesions in the skull, and both conditions, this sarcoid and this will result in diabetes insipidus. Then, if you have a child with this appearance, you think of Langerhans cell histiocytosis. If you have a female postpartum, you think of lymphocytic hypophysitis. If not, you consider sarcoid. Yes, this is the case of pituitary gland and T1, T2 post contrast. Yes, pituitary abscess, no. Hemorrhagic adenoma, right. This is a pituitary hemorrhage. Bright signal in the T1, bright signal in the T2, no post-contrast enhancement, and this is hemorrhage inside the pituitary adenoma. You may say pituitary apoplexy, you may say hemorrhagic pituitary adenoma, all can fit for the diagnosis. This male patient with endocrine disturbance, and this is the MRI of his pituitary gland, T1, T2, T1 post contrast, coronal and sagittal. Adenoma, Russell's cleft, microadenoma. Yes, microadenoma on the right side of the pituitary gland, this one. Russell's cleft cyst is centered underneath the pituitary stalk, and it shows cystic criteria of similar CSF signal intensity. It does not enhance with contrast Unless if it is large, it may show some marginal post-contrast enhancement, but the most common focal small lesion in the pituitary gland is pituitary microadenoma. This is MRI of the temporomandibular joint. Anterior dislocation with reduction. Yes, this is a right answer. You can see that the articular disc is slightly dislocated anteriorly. It is not fitting between the eminence and the condyle. In the closed mouth. In the open mouth, the disc maintains its normal configuration and the position between the temporal eminence and the mandibular condyle. And this is anteriorly dislocated reducible disc. Female, 10 years old, with حاضر يا سعادة الباشا. Okay, I will explain what you want. I don't know if you wanted the mandibular discs of the mandible. Yeah, you know that the articular disc is like a babyon configuration. It has a anterior mass, posterior mass.
Recording in progress.
It is not in progress. Okay. Okay. I hope that you hear me now. This is the articular disc in normal conditions, both in the closed mouth and open mouth. This narrow part of the disc should be located between the temporal eminence and the mandibular condyle, and this narrow part is slightly displaced anteriorly. But in the open mouth, the narrow part is exactly between the temporal eminence and the mandibular condyle. So the disc is anteriorly displaced in the closed mouth and retained its position in the open mouth. This is known as reducible disc. But if the disc remains anteriorly displaced even in the open mouth, then this is irreducible disc. And these are the three conditions seen in the temporomandibular joint. A normal disc, an anteriorly displaced reducible, or anteriorly displaced irreducible disc. I'm sorry for the interruptions because the net is not stable, and I am also recording this lecture, and I will put it in on my site so that you can
Recording in progress.
so that you can hear it with continuous recording. Okay, then we shall proceed into the next case, and this is a female child, 10 years old, with, as you can see, bilateral optic nerve masses that also extended to involve the chiasm with intracranial extension, as you can see here. Then the diagnosis is easy as the case before, and it represents a neurofibromatosis type 1 because of the bilateral optic nerve involvement and also chiasmatic involvement. Okay, and this is optic and the chiasmatic and also hypothalamic glioma. And next case is a maxillary sinus with an opacification. Yes, and this is inverted papilloma. Our anteroconal polyp is right, but inverted papilloma is not, because in inverted papilloma you should see that the nose is expanded but the sinus is not. And if the sinus is expanded compared to the opposite side and the ostium is wide and the nose is not expanding, then you are dealing with an anteroconal polyp. Then you may say that you have said that anteroconal polyp is not associated with ethmoidal sinusitis or opaque ethmoids. This is true, but this is not a constant fact, of course, because the patient may have anteroconal polyp and ethmoidal sinusitis. But commonly, in cases of anteroconal polyp, the ethmoids are clear, while in inverted papilloma, the ethmoids should be definitely involved. Then this is anteroconal polyp. This is okay. Then what do you think of this lesion and an enhancing lesion in the pharynx with this classic extension through the pterygopalatine fossa, and this is angiofibroma. Yes, this is right. The angiofibroma has this very classic extension through the pterygopalatine fossa. This is the normal pterygopalatine fossa, and this is one which is widened and involved with extension of the lesion into the infratemporal fossa, and it has a great affinity for involvement also of the sphenoid sinus, together with significant post-contrast enhancement, and this is nasopharyngeal angiofibroma. This patient with what looks like an extensively sclerotic lesion affecting the greater wing of the sphenoid and also some of the lateral wall of the ethmoidal air cells, the pterygoid plates associated with this mass. Actually, I know that this is a difficult case, but you may collect these facts to reach a diagnosis. Langerhans cell histiocytosis would erode the bones rather than produce a sclerotic reaction. I think that there is only one lesion which is able to produce a significant bone sclerosis without destructive changes, and is associated by a soft tissue component. And this is actually an odd presentation for a meningioma of the skull base or the maxillary sinus. But I presented this case in order to put in your mind that a lesion with significant bone sclerosis like this is usually a benign lesion, and meningioma should be on the top of the differential diagnosis. Then this patient with maxillary sinus lesion by CT, by coronal CT, and by MRI. And actually, these loculi of air are the sequelae of the previous biopsy taken from the maxillary sinus. If you feel that this lesion is destructive, then you consider carcinoma. Yes, you consider carcinoma. And if you feel that this is only an expanding lesion without bone destruction, you should revise your feeling, because there is significant destruction of the anterior wall of the maxillary sinus, the medial wall, the pterygoid plate, and part of the bony nasal septum. Then whenever you see destructive changes, the first of all on top of the list is the carcinoma. This 14 years old male has referred to the dentist for extraction of a painful carious mandibular left first molar tooth. Okay, keratogenic cyst, very good. This answer because I think that this is the only cyst which is multiple cystic lesions in the mandible. You see a big one on the left side and another one on the right side are usually pathognomonic for the keratocyst. This is a simple case of yes, osteoma of the maxillary sinus. Good. The answer is good. This is maxillary sinus osteoma. This is not fungus because it is dense as much as the bone. And the sinus, the fungus cannot be as much in the density. Next case, and you see uh, lesion in the floor of the mouth, another lesion in the submandibular salivary gland, the third lesion near the submandibular salivary gland on the left side with some air loculus inside, then you consider abscesses, yes. And these are multiple abscesses in the floor of the mouth, in the submandibular space, and submandibular gland on both sides. This is mouth floor infection. This is a female, 37 years old, with an incidental finding at CT scan performed for suspicious sinusitis. There is no evidence of sinusitis, but there is a cystic lesion which is arising in the alveolar margin, and this is not a retention cyst. It is in the alveolus, not in the maxillary sinus, and is surrounded by bone, and is unilocular in appearance. And of course, it does not show malignant criteria. Simple bone cyst is not that common in the mandible or in the alveolar or in the alveolus, but the keratocyst is a good possibility since the cyst is unilocular. And of course, you know that ameloblastoma is also unilocular cyst that can arise in such an appearance, and you may not be able to differentiate. If you are asked about what do you prefer for the diagnosis, you should say that I prefer ameloblastoma or adamantinoma because it is more common than the keratocyst. This is a classic appearance of yes, and this is an osteosarcoma of the mandible with the classic sun ray speculations typical of osteosarcoma in the mandible. And this is also an appearance of osteosarcoma in the mandible with sun ray speculations and a big soft tissue mass surrounding the affected mandibular ramus. This female child with long-standing left nasal stiffness. And conca bullosa, no, this is choanal atresia. And you know that the posterior choana is obliterated by bone. You have two types of choanal atresia, the soft tissue atresia, where you got a membrane obstructing the posterior nares. But if the obstructing lesion is bony, you got bony atresia of the iguana. The guanal atresia may be unilateral or bilateral, soft or bony types. Yeah, okay. Ameloblastoma, good. Yes, this is good. Actually, simple bone cyst, aneurysmal bone cyst, and most of the bone tumors are rare in the mandible. You think of odontogenic tumors more common than the non-odontogenic tumors. Then a very common lesion or well-known lesion in the mandible is ameloblastoma, and this lesion is classic for ameloblastoma. You can see the expansion, you can see the erosion of the related tooth root. Okay, and this is also a classic lesion. Carotid body tumor, yes, this is good. The carotid body tumor with a lesion which is located in between the carotid bifurcation, the internal and external carotid arteries, and the lesion is centered in between. It's a strongly enhancing lesion, diagnostic of carotid body tumor. Then this is MRI of a patient presented by painless swelling in her neck 10 weeks ago. This is T2 weighted image, and this is T1 post contrast fat set. T1 post contrast fat set. This is T2, not T1. Second, the branchial. Yes, branchial cleft says second arch. Typical location, anterior to the sternocleidomastoid muscle, posterior to the submandibular salivary gland, lateral to the carotid vessels. Okay. This patient is 72 years old with large ulcer in the floor of the mouth. Yes, and this is not an abscess actually, this is carcinoma. You see how much the destruction and the erosion of the inner mandibular cortex with infiltration by this heterogeneously enhanced mass. I said you should consider carcinoma in these particular locations unless you have a good evidence of inflammation. Also, you can see this necrotic lymph node, which represent a metastatic deposit from this mouth floor carcinoma. This is the classic appearance of, yes, this is a cyroglossal duct cyst, midline cystic lesion, and in the neck anterior to the larynx at the level of the hyoid bone, with no significant post-contrast enhancement, diagnostic of cyroglossal duct cyst. This is CT, and this is MRI T1 and T2 weighted images of a lesion in the larynx. And this is not ranula because it is bright in the T1, meaning that it is, no, it is not a laryngocele. Bright in the T1, bright in the T1, meaning fat. Yes, this is lipoma. And lipoma is black in the CT scan, bright in the T1 and less bright in the T2 weighted image. This is laryngeal lipoma. This the male patient, 70 years old, with hoarseness of or sore throat for 2 months, showing a mass on the right side of the larynx. Then this is laryngeal carcinoma. The most common tumor of the larynx is laryngeal carcinoma, and it infiltrates both levels, the glottic, and also extends somewhat supraglottic and infraglottic as well. This is laryngeal carcinoma. Sometimes there is overlap between laryngeal carcinoma and the carcinoma of the piriform sinus. The piriform sinus is related to the pharynx, while this area is related to the larynx. And whenever the tumor is large enough, you can sometimes cannot differentiate between both. This patient with renal cell carcinoma presenting by a neck mass. The answer is easy. Yes, metastasis, and whatever the metastasis in the lymph nodes, metastasis in the muscles, metastasis in the larynx itself, all can fit by for metastatic deposits, since you know that the patient had a primary malignancy. Yes, we have mentioned a similar lesion before. Yes, if the lesion is filled by fluid, it is a saccular cyst. If it is filled by air, it is a laryngocele, and this is mixed saccular cyst because it has a component inside the larynx and another one outside the larynx. This is also CT scan of the larynx showing this mass in relation to the to the left side of the cricoid cartilage. Chondrosarcoma, yes, this is right. Chondrosarcoma is one of the lesions frequently seen in the larynx, but of course it is not that common compared to laryngeal cancer. Because there are a lot of cartilage in the larynx, and chondrosarcoma can arise from any of these cartilages. Commonly, the most common cartilage affected is the cricoid one, and you got an aggressive mass with destructive changes and matrix calcification, then you diagnose chondrosarcoma of the larynx. And this is also a laryngeal lesion which affects the area epiglottic fold, the true vocal cord, and extends a little bit in the to the level of the cricoid cartilage. Then at this time you should not say supraglottic, but you say transglottic carcinoma, which can involve the three laryngeal levels: the supraglottic level, the glottic level, and the infraglottic level. Then this patient with this lesion, and this lesion is not a second branchial cleft cyst because it is not a cyst actually. It is it looks like a mass with central breakdown. It is not in the in the submandibular and not in the parotid to say pleomorphic adenoma. Yes, this is the necrotic lymph node. Necrotic lymph node, which is located in this site. You know that this site is the site of the submandibular nodes, and this is one that is enlarged with necrotic center. Necrotic lymph nodes are either inflammatory or neoplastic, and the inflammatory nodes are, whenever they are necrotic, they simulate the abscess or regular enhancing wall. But whenever the wall is irregular and you got some infiltration of the surrounding fat, and you think of a malignant node, and this is metastatic lymph node. Okay, this is the male patient, 80 years old, with hoarseness of voice and stridor. with past history of resected papilloma. Yes, we are waiting for the internet.
Recording in progress.
Okay, then this history will, sorry, this history will give you some clue about the right answer, where okay, I am sorry for this disturbance because the net is fluctuant, and uh, sometimes there is interruption of the internet, and we have to wait until uh, uh, the regain of the connection. Then okay, in order to buzz quickly through the remaining cases, if you have the history of previously resected papilloma, you know that the patient had what is known as vocal cord papillomatosis or laryngeal papillomatosis, which is a condition associated with papilloma virus infection when the patient suffers from recurrent papillomas that are frequently resected. And this papilloma is not a pre-malignant condition. And of course, if you have this configuration and the exam or in the clinical practice and you do not have positive history, you say that this is glottic carcinoma until proved otherwise. But if you have the history, you may reach the right diagnosis. This is actually a carotid body tumor because of the salt and pepper appearance with a bright signal of the tumor matrix, and the signal void vessels inside the tumor represents the pepper. Then this is a spot diagnosis of a laryngocele containing air, and this laryngocele has part inside the larynx and part outside the larynx, diagnostic of mixed laryngocele. And these images for the nasopharynx showed the typical appearance of thorn-walled cyst, which is located exactly in the midline. It may contain proteinaceous fluid, so it will appear of some brightness in the T1 and less bright in the T2, and may show a mixed signal in the sagittal images. This is torn-walled cyst, an incidental finding, and they should not be stressed in the reports.
Recording in progress.
Okay, and that's also there were some interruptions, internet interruptions, and this is an intraocular mass with enhancement denoting intraocular melanoma, and this is the final case of a lesion inside the orbit with multiple fluid levels, diagnostic of intraorbital lymphatic malformation. Thank you very much. I'm sorry for this multiple interruptions, and I wish for you the best of luck and in the exam and in your life. شكرا جزيلا.